So I've given you the weight there. That is already a clue of what you need to do. Right, okay. So you start them on low molecular weights, and here they use enoxaparin, 175 units per kilogram. So that's how you work it out, how much you give them. And then you just round it up, because nurses don't like, point whatever, they'll round it up. So 13,000 units. So you need to remember that on top of your head, 175 units per kilo, okay? And you also start them on warfarin at the same time. So you prescribe the warfarin on the chart, as well as the actual warfarin charts. Have you all seen the drug charts and the warfarin charts? Mm-hmm. Yeah, you have them. Good, good. Okay. So usually, the guidelines say load them with like 5 or 10. For more susceptible patients with sort of heart failures, more comorbidities, it will be 5 low dose. But this patient, you can argue he's relatively stable-ish. So you would start him on 10, and then you would do a level. Often on the ward, we would do 10 and 10, and then a level. But the guidelines say load with 10, and then do a level. Is that clear? Can everyone manage a PE now? When you get a call from the radiologist, you're not going to be panicking and looking at you know what to do. You can always look it up, obviously, but it's nice if you know it. So there you go, treatment dose, 175 units, and warfarin. And for renal patients, it will be enoxaparin, don't forget that, that's really important. One thing I forgot to tell you is, if they're on prophylactic tins, you need to cross it off. Okay, don't forget that, because a lot of patients in hospital will be on prophylactic tins, so make sure you cross that off.
Why do you do the word renal failure, sir?
Because that's the renal low molecular weight heparin. You always give enoxaparin for renal patients, always.
Is that the same dosage, the same units? Or?
So it's usually 20 milligrams is usually the standard renal dose. But it is something that you need to look up, because sometimes they can give 1 milligram per kilogram. So if someone's got chronic kidney failure, I would look that up and consult with that, because that's a bit more specialist, isn't it? For renal you do need to. Yeah, so just be careful with renal patients. And then one thing that you have to write on the enoxaparin side is they need to stop it when their INR is more than 10. So make sure that you actually write that, because if the nurses are not gonna think, they'll just keep giving tins and warfarin, and then they can bleed to death. So make sure you say stop it, and you check the INR.
Is that over 2?
Over 2, yeah. Equal or over 2.
Sorry, what was that? When they after 3 days of being on enoxaparin?
Yeah, everybody's different. So some patients will pick up very quickly. Some patients will take them ages to get their INR above 2. But you need to not forget to stop the tinsiparin when the INR is more than 2. Okay, so that's your standard warfarin chart. It's very good because it tells you exactly what's the target INR and what's the duration. So in this case, our patient had a proximal PE, so they'll need to be on the warfarin for 6 months. Okay, so it's all written down. You don't need to sort of remember it, but it's roughly 3 to 6 months. And obviously for valve surgery, it will be lifelong. And that's the back of the chart. Like you were saying, patients that will be more sensitive to warfarin, they need to start on a lower dose. So elderly patients, I would probably start them on 5 rather than 10. But as long as you do an INR, then you're safe. With warfarin, it's all about just, you know, making sense of it, getting the INR, prescribing according to your INRs, and you wouldn't have a problem with it. So that has been previous OSCE, actually initiating warfarin, because you do that all the time. On any ward you go, you will have to do patients with warfarin. So make sure you get your head round. So after the patient goes home, it's your job to refer them for a warfarin clinic. So on this chart, this is the actual anticoagulant referral used in this hospital. So what you do is just obviously state why they're on warfarin, their target INR, and this is where you put their latest INR results, and then you make the appointment and you tell the patient why they need to have those appointments, etc., and their regular checks. So I'm just going to go through it briefly because you're probably all bored now. What the kind of things, I mean, we can't teach you sort of how the OSCE is going to go. The communication skills are very difficult to teach, and it all depends on the day and your performance. But if you've practiced it lots of times, if you know the basic things you need to cover, and with communication skills, it's really sort of the basic things, because patients, you know, they're not from a medical background, so as long as you explain it in like a very sort of easy and non-jargon way, then you will pick up the marks. And there's a lot of, in comm skills, it's always like, you know, patient's lifestyle, have you addressed their concerns, their ideas, you know, making sure that you mention about the side effects. Compliance with warfarin is so important. So you need to talk about that. So explaining what the INR is, you know, if I was a patient and I told you, okay, what is INR? Like, what does it stand for? What would you say to me?
Yeah, sorry, it's the international. We wouldn't really count that, but it's just a way that you look at how well their blood's clotting.
Good. Yeah, very good. See, nice and simple. That's it. That's all they need. Okay, and you give the yellow book and tell them about the side effects and the fact that it interacts with a lot of other medications, with a lot of other foods as well, high vitamin, as well as alcohol. And sort of, we did have a station with a lady that was trying for a baby, and she was also on warfarin, etc. So a lot of the marks were sort of addressing the pregnancy issue side of things. So, like I said, lifestyle and pregnancy and sort of that kind of issues are very important in comm skills. And you need to.
Can you change it with pregnancy?
Sorry? No, you can't. You have to stop it because it is teratogenic.
So what do you do? Put on something
So
else?
you give them heparin. It's very difficult. It is very, and that's why it comes up, because it is a difficult scenario, and you need to know that, you know, in pregnancy it is teratogenic, so you have to stop that.
Can they take the oral contraceptive, but just they have to take a different dose, or can they not take it?
Well, it's safe with the POP, I believe, but not with the combined one. Yeah, but I'll look that up definitely. Something to look at contraception. Yeah. And the other thing is surgical procedures. You need to warn them that if they're going for any kind of surgical procedure, even if it's a minor dental op or something, they have to stop the warfarin 5 days before.
And then she bridge them. And then she bridge them with the right hand.
Well, it depends on what they're having. If someone is having major surgery, they'll be coming into hospital for it, so they will be on low molecular weight heparin for that. If somebody, now you tell me, if someone needs to take warfarin for valve replacement, it's very important they stay on the warfarin, because that's for lifelong, and their valve can actually erode and everything if they're not on warfarin. What would you do then? Because low molecular weight is good, but it's not as effective and it's easily
Heparin infusion.
reversible.
You even have
Yeah,
infusion?
you have to start them on heparin infusions. And the problem with heparin infusions is you have to do the APTT ratio every sort of 12 hours, etc., depending on how stable they are. So when you have patients like that, you need to monitor them all the time with the heparin infusions. Is that all right? Is that clear? Yeah. Fine. So yeah, that's conclusions.
Yeah. I think that's everything we've been through. So let's go. Yeah, go on.
Normally, like before we start heparin, we were told to like do LFTs and coagulation and stuff. But you were saying that in the context of the PE to start, the warfarin, you were saying to start it immediately. So
Yeah, I mean, what's going to kill them first is if they have some, mild derangements in their LFTs or their PE. I mean, you would definitely do that as baseline because you're going to have to take bloods anyway, so you would do the LFTs. But you need to start them on treatment because they may die from PE. Yeah.
So with the warfarin, when you're starting them off, would you tell them like what is like 555 or whatever? Like, would you tell them?
I don't think many of them really care what they start on. There's no harm in telling them.
Would you need to like fill in the form?
Yeah, so on that yellow form you write 552, whatever it is, and tell them you're just loading them first, and then we're going to check your blood every 2 days to start with, and then again in every week, then every 2 weeks, and every month, and every 2 months. Anything else? So just go through those questions again. So differential for painless leg that we spoke about, medical emergency. Yeah, and the one that we spoke about. Quite good. Which bones is where's the posterior pulse? Excellent. What's the TAP test for? We knew that already anyway. What do you give for VT and renal failure? Good. And what's treatment of for PC? Great. Anything else you guys want to ask about anything? Okay, thanks a lot, guys. Guys, what's the feedback forms? I know it's a pain in the ass, but we have to do it. It's